So, with approval of pembrolizumab in MSI-high tumors, stage 4 diseases, solid tumors, how often do you check stage 4 prostate cancer for MSI-high, and what kind of response do you see?
So, it's a great question. Molecular analysis of prostate cancer metastatic lesions is a little tricky because even at very experienced centers that do a lot of tumor biopsies, and we've done initially for research and now for clinical care metastatic biopsies in several hundred patients, even then, probably a third of patients you can't really get a good sample on. The numbers look better in the literature because of all the patients that never make it to a biopsy attempt. But our practice is to send a note to our radiologist first to assess feasibility of a CT-guided biopsy. And at the end of the day, I think about 2/3 of patients can have a biopsy. If it's bone only, you get a pretty small sample for analysis, and so that's also tricky, and the decalcification regimen has to be different than the normal sort of approach for histologic analysis. So it's not super straightforward to do that. MSI high in prostate cancer is something that you find in a couple % of patients maybe. I don't know the exact number. What's that? Yeah, I mean, it's a very small number. So it's hard to justify, I think, biopsying 50 patients to find one. So we've been doing it with for research, and many of our patients are enrolled on trials that include genomic analysis. And increasingly with a broad panel, we have a Gene Trails panel at our center. UW has a different one. There's Foundation. There's several. We're looking for more than just MSI. We're looking for DNA repair deficiency, BRCA1, BRCA2, PALB2 mutations, and other things, sort of trying to get at this genomic map. I have not been finding a lot of MSI by doing that, but I think if PARP inhibitors get approved based on molecular features and we begin to get to a place where molecular analysis yields something useful for a quarter of the patients instead of 1 or 2%, then I see the field moving towards kind of routine molecular analysis in most patients. But Evan, do you have a different view on that? Or?
No, not at all. I agree with you. I would say that probably most of our patients do get some sort of molecular testing at some point in time with MCRPC, however, and a lot of that is on a study because, but most of these studies we have built in where the patient can get the information back, so we can utilize that, whether it's, some sort of, we all participate in the Stand Up to Cancer type of studies. We have additional studies where we're doing UW Oncoplex, which is our homegrown Colin Pritchard's assay that he uses. And, they look at mutational load, they look at microsatellite instability, and they offer DNA repair alterations. They look at CDK12, all these different things. So I agree. I think, it makes a lot more sense when you can cast a broader net. But at this point in time, it's still pretty researchy. What is out there for, I would say, standard of care use would be MSI status, but it's complicated, right? It's complicated. It really is. I mean, we have patients where we do germline testing on, and they have some of the classic genes, MSH2, MSH6, MLH1, and they don't have microsatellite instability, and they aren't, hypermutated. So it's complicated.
So, what do you see the sensitive and liquid biopsy?
Sensitivity of what?
Liquid biopsy.
Oh, yeah. I'll say that, that is early, and we're doing a lot of concordance studies right now at our center. Mike Schweitzer at our center has...
Just hold the mic closer to you.
Okay. Mike Schweitzer at our center has some studies that he's done with Colin that show that if the PSA is greater than 20%, the concordance rate is basically... PSA is greater than 20, the concordance rate can be basically 100%. But it depends on the assay, and the most important thing to recognize with next-generation sequencing is not necessarily what your assay is, but who's interpreting it. It's similar to radiology, right? It's like you can get an imaging study and you can spend tons of money on a 7T or 13T, 55T MRI or whatever like that, but what really matters is who's interpreting it. And so I think that's the important thing.
I think, I've had sort of a mixed experience with liquid biopsies. I've detected some, what in retrospect turned out to be clonal hematopoiesis, which I got all excited about and then realized that that's not what I'm looking for. So I have not incorporated liquid biopsies into my routine clinical workflow at this point.
So I will say this. I will say the thing you have to keep in mind is, I'm probably going to say something maybe not so PC here right now, but what is the incentive? Okay, as clinicians, we are all incentivized to try to find something to treat our patients with, right? But we have to remember that if we start calling all kinds of things that are questionable, we get false positives. And we might be doing our patients a disservice by treating them with some targeted therapy that is not going to benefit the patient, and maybe we're doing them a disservice because they could have benefited from some other standard of care agent. So I think you have to keep that in mind as a physician and as a company that's doing next generation sequencing. Certainly they want to show their utility, that they're detecting things that could be clinically useful. So again, we're doing this mostly with research, and we have our, I'm sure, interests as well, but I think maybe I'm hoping a little less financial interest since it's a homegrown research assay. So
I think the thing that we are facing in the community with so many drugs is that our patients are living longer, have gone through all the agents that have been listed, and we are seeing a lot of patients who have preserved performance status. And we are seeing the prostate cancers are behaving differently with visceral mets, with liver and lung metastases, and they've had prior cabazitaxel and docetaxel. How are you treating those patients in that setting?
So first of all, I would draw a pretty clear distinction between liver and lung. We do group them as visceral, but if you look at the data that's out there, certainly the data from PREVAIL, for example, and also experience, people with lung mets do quite well. And I've had patients who've had lung mets from the time of initial diagnosis, not just late. And I've had folks who develop them late, and they don't have a discernibly different outcome than patients without lung mets that have, lymph node and skeletal mets. On the other hand, liver metastases are a dismal sort of thing, and the vast majority of those patients do poorly. If you look at the subset analyses with PREVAIL, they did poorly. If you look at subset analyses with docetaxel, they also did poorly. There's nothing out there that's really a clear positive signal. I will more often than not biopsy those patients and try to understand their biology. We've been using taxane platinum combinations on the basis of small, primarily MD Anderson based studies. We also published a docetaxel carbo paper quite a while ago together with William O. We've done that. Phase 1 trials, but it's a very difficult problem, and folks who develop liver mets, in my experience, have a lousy prognosis and don't respond to much of anything. You have a solution for liver mets up here?
Not really. I mean, I agree completely with what you said. I would just say that I also try to biopsy all patients who develop liver mets, and the things I'm looking for, and I think your hit rate's going to be higher for these patients, is DNA repair alterations like BRCA2, CDK12, et cetera. Going to look for mismatch repair alterations and microsatellite instability. And other things, obviously neuroendocrine carcinoma, so synaptophysin, chromogram, and histopathologic staining. These are all things that could affect your treatment paradigm, treatment options. And I'd say something a little bit more researchy and a little more homegrown is we're looking at things like double negative status, and that just is patients that have lost AR status, patients that have also do not have chromogram A or synaptophysin. They're kind of just don't express any of these markers. Pete Nelson from our center has some data looking at fibroblast growth factor receptors and that they're potentially driven down that pathway. So Mike Schweitzer is going to be opening a trial using erdafitinib in those patient populations. So there's a trial option. And the last I'll just say is this whole lineage plasticity, anaplastic type of thing. You know, a lot of these patients have lost RB, and RB coupled with either P10 or P53, that's a poor prognosis. And we're trying to shuttle patients like that onto trials where we're using things like AZH2 inhibitors, bromodomain inhibitors, maybe in combination with IO, et cetera. But again, all researchy. So, but those, we're seeing more and more of this, and we do the doublet with taxane platinum thing as well when we find nothing to go else to go after.
I think that concludes this session. Thank you to both Dr. Beer and Dr. Yu. 11 o'clock will be the next session.